Good morning, good afternoon, and good evening, depending on where you are joining us from. And welcome to today's AMR Community of Practice that hosted by ASLM. My name is Patience Dabula, and I'll be your moderator today. We are honored that you chose to be with us today. Please note that there is simultaneous interpretation available from English to French and also from English to Portuguese. Select the language that you prefer by selecting the interpretation icon on your device. Today's webinar is entitled Antimicrobial Stewardship Implementation, Best Practices and Sharing Experiences. Our speaker will explore how antimicrobial stewardship, when implemented effectively, can improve patient care, preserve antibiotic effectiveness, and reduce the spread of resistance. Before we begin, I kindly request that you keep your mics on mute and also use the Q&A section for your questions. We use the chat section for the links that you may want to share with us or additional resources that you know are relevant to the topic being presented. And the session has been recorded. It will be available via the SLM Academy portal. Remember, again, we have interpretation. Choose the language that you prefer to listen to. I'm glad to introduce Prof. Omai, who is with us today. Good morning to you, Prof.
Good morning, everybody. Bright and early in Los Angeles. Good morning.
Yes. Thanks for joining us. Prof. Garner is a clinical professor and director of the clinical microbiology in the UCLA, University of California, Los Angeles Health System. He served his PhD in biomedical sciences from University of California, San Diego, and went to complete a postdoctoral clinical microbiology CP-EP fellowship in the Department of Pathology at UCLA. He is also a former McNair Scholar. He's registered and certified by the American Board of Medical Microbiology, and his research focuses on novel point-of-care devices for infectious disease diagnostics in low and medium income countries. Prof, we are honored to have you here as ASLM. We are glad that you made your time. We hand over to you to take us through your presentation. Thank you.
Wonderful. I'm honored to be here. Thank you so much for the invitation to speak to the African Society of Laboratory Medicine. I'm very excited to share today's talk. So as Patience mentioned, this talk is about antimicrobial stewardship implementation, best practices, and sharing experiences. But this talk is really about the role of the laboratory in stewardship. You know, I think often stewardship is thought of as physician intervention into antibiotic usage, right? That's sort of the goal of stewardship. And while I will agree that that is one of the goals of antimicrobial stewardship, as we are faced with an antimicrobial resistance crisis, global crisis, I really want to engage us as laboratory professionals to understand our role in this space, the critical nature of our role in this space, and how the lab can help fight antimicrobial resistance, and how the lab, importantly, through its role in antimicrobial stewardship, can help in patient care and fighting antimicrobial resistance. So that's really, that's really the pitch today, is what we can do as laboratorians. And my hope is to be able to inspire you as laboratorians to approach your own institution and really work in the stewardship space for patient care. So our objectives today, my objective is to introduce the principles, goals, and challenges of antimicrobial stewardship programs and share some successful implementation strategies. So I'm going to take this talk from the perspective of the UCLA Health Antimicrobial Stewardship Program, of which me and some of my lab faculty have been involved since the beginning. For the last 15 years, we've been a member of our stewardship program at UCLA. This is an introduction to our program, and I want to sort of walk you through who are the members of our stewardship program so you can get an idea on what group we have that is really addressing antimicrobial stewardship at UCLA. So we meet once a month and have various projects going on. We have 2 medical director leads. These are infectious disease physicians. One, Dr. Vajayan, is an adult infectious disease physician, and Dr. Kaur is a pediatric infectious disease physician. We have a 3rd physician on the group, and her specialty is infection prevention. And so she is actually one of our co-chiefs of infection prevention because of this strong connection between infection prevention and stewardship. We have 4 infectious disease specialist pharmacists that are on board to be able to work around antimicrobials and antimicrobial distribution. I am there, and Dr. Suki Chandrasekaran, who is my associate medical director in the microbiology laboratory, she also serves on the team. Her specialty is antimicrobial susceptibility testing, so she is invaluable to this space. We have our system director for infection prevention and another one of our infection prevention chiefs that's on. We have a couple of data analysts, and this sort of in the day and age of more and more data and how we use that data most effectively for healthcare. It's important to have people like that. And then we have one of our nurses who is an infectious disease transition service specialist. And her role is really about outpatient antibiotics, right? And how stewardship can take a person from the hospital who's on antibiotics and transition them out of the hospital while still on antibiotics. So you can see cross-departmental team, multidisciplinary team, and this is really the best way to try and combat antimicrobial resistance. So what is our goal? What is our mission overall as a stewardship program? Our mission is really to improve the care of patients with infectious disease while also supporting appropriate use of antimicrobials. And so we use this diagram as sort of a walkthrough where you have a susceptible pathogen and you try and do everything that you can to prevent infection, right? Whether it's infection within the hospital setting, through infection prevention, but ultimately people are going to get infected. And once they are infected, we really want to have the most effective diagnosis and treatments. Like you can imagine sort of this red area here, really where laboratory is super important to this circle, right? Because in infectious disease diagnosis, you can't have effective diagnosis without great lab. And so then we talk about antimicrobial use and the optimization of that use, right? Right drug, right dose, right patient. Because if you're able to get those 3 things correct, using the lab data appropriately, then what you are able to do is combat antimicrobial resistance, right? Less broad spread antibiotics, less overall inappropriate antibiotic usage. And what this ends up doing, of course, is preventing transmission. And if you're preventing transmission, you can keep pathogens susceptible to your antibiotics. So you see this circle, this model represents the inputs and the goals that we have through our stewardship program. So if we look overall at the goals of antimicrobial stewardship, right, I think sort of we started in the very beginning, we want to reduce antibiotic resistance. But the goals of antibiotic stewardship are actually broader than this, right? They're in line with the overall healthcare goals. So if we ask this question, which of the following are common goals? The answer is all of these are goals, right? We want to improve patient outcomes. This is the reason why all of us have gone into healthcare. This is the reason why every single laboratory professional on this call got into healthcare, is we care about patients. We want to reduce adverse events. We want to reduce antibiotic resistance. And then most importantly, resources are at a premium everywhere. And while different places have different accesses to resources, all resources need to be used optimally. So in this setting, all of these pieces come together to assist in our goals as a stewardship program. So what is stewardship sort of as a whole? So there are organizations like the Infectious Disease Society of America or SHEA or PIDS that address stewardship, and they have a definition. And their definition is really coordinated interventions designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antimicrobial drug, that drug regimen during dosing, duration of therapy, and route of administration. And so you have these 5 rights of antimicrobial stewardship: patient disease, drug, dose, duration, and route. And if you're able to sort of coordinate these efforts, and the difficulty here, you can imagine, right? For all of you working in healthcare systems, how many patients get infectious disease? So many patients have some level of infectious disease. They've all got different bugs, they've all got different drugs, and they all have a different biology, right? Even their human biology and their reaction to those drugs. And so you can see stewardship is very individual, right? Getting this right and setting this up correctly is individual to the patient, but then always improves patient outcomes. Why is this important globally? And, I feel I'm a little bit preaching to the choir here. This is a group of laboratory professionals, but when I go out and give this talk to others who aren't as aware of the importance of stewardship, this really hits home. We really are in the midst of an antimicrobial resistance crisis. Now, we're also in the midst of a COVID crisis and a Candida auris crisis. And for us in Los Angeles, we have a coccidioides crisis and a syphilis crisis. Infectious disease is a crisis, but this one, antimicrobial resistance, really needs to come to the forefront in our minds in order to battle. So if you look at the numbers, and I'll use US and global numbers, there's more than 2.8 million antibiotic resistant infections that occur in the US every single year, and more than 35,000 patients die. These are low numbers compared to the numbers we find globally. Sepsis contributes to over 1/3 of in-hospital deaths and is a major driver of new morbidity in those who survive. COVID made all of this worse. So if you look at COVID-19, it had a major impact on antimicrobial resistance. 15% increase in infections and deaths due to antimicrobial resistance, and an increase in 4 out of 6 types of hospital-acquired infections. Why did this happen? We were all focused on fighting COVID, right? It was the outbreak of the moment. We had to come together as a healthcare community, as a laboratory community, to face this unprecedented disease. But at the same time, other diseases were happening. And so as we were all so focused on battling COVID, unfortunately, we saw increases in antimicrobial resistance. If we span out globally, $3.4 trillion annual GDP loss, 10 million annual deaths, and 24 million more people pushed to extreme poverty within the next decade. And this graph over here, this chart over here, really shows the impact globally on estimated deaths and antimicrobial resistance. So if we look at estimated deaths overall, sort of some of the number 1 killers here: diarrheal disease, diabetes, cancer. And as cancer is sort of the number 1 disease estimated to be a killer around 2050, you can see the AMR number will reach that high as well. So again, really, I can't overemphasize the crisis that we're facing. So looking at the structure of stewardship programs, the CDC, so the Centers for Disease Control in the US, have defined some core elements of stewardship. Some of the core elements include hospital leadership commitments. And I will argue that the hospital needs to be on board and put resources into stewardship. Accountability, pharmacy expertise, tracking and reporting. And then there are multiple regulatory bodies that are also involved in this process. Now, when we look at stewardship intervention, meaning how do we assist clinicians in antibiotic usage, there's a couple of ways you can do this. There's pre-authorization methods. So these are upstream methods where if a provider wants to order an antibiotic, they can't just order an antibiotic. They can't say, I want vancomycin for my patient. No, there are restrictions that can be put on board and say, well, you can only have vancomycin if, and then this, and this. And you set those restrictions based on laboratory data, based on things from the patient. And these can be impactful. Then there's also that's pre-authorization. There's also prospective auditing. And prospective auditing is really this idea of intervention on cases as they are happening. So the lab identifies a methicillin-resistant Staph aureus bloodstream infection. The lab notifies stewardship, the medical team on stewardship, to then go to the patient bedside to assist in the care of that patient. So you can see how that intervention then can work very specifically. But the key point that I will make is that whether it's pre-authorization or prospective audit, laboratory data is going to be essential. And the availability of laboratory data is going to be essential for the success of this type of program. So looking at the Joint Commission, which is one of the regulatory bodies in the United States for all hospital efforts, they have areas that allow for the establishment of stewardship as an organizational priority. And so the Joint Commission keeps hospitals licensed in the United States. And so because of that, they've made stewardship a requirement. And it's important to be able to have stewardship a high enough priority that it's a requirement for a hospital to have. So this is what Joint Commission says. A hospital must allocate financial resources to support stewardship. A hospital must appoint a medical lead for that, and that group must follow national guidelines and standards. 13 is important. The Joint Commission says specifically the committee needs to be multidisciplinary. It can't just be a couple of MDs running the program. You need to have lab. You need to have pharmacy. You need to have nursing. And then moving through, there needs to be coordination amongst components of the hospital for antibiotic use and resistance. You need to document evidence-based use of antibiotics in various departments. Monitor those antibiotics on a regular basis using things like days of therapy per 1,000 patient days. You have to implement evidence-based guidelines, adhere to those guidelines, collect your data, analyze it, and report it. Remember, we talked about the role of data analysts inside these things, and then take action to improve. So I want to show how we're doing this at UCLA, because these are wonderful guidelines, but they're broad. They don't specifically tell you, here's how you implement, here's how you do. So I want to give you some very specific examples. So one is it's important to make sure that stewardship communicates as well as possible as it can with the entire health system. Infectious disease doctors are not the only doctors that can prescribe antibiotics, right? And antibiotics are one of the #1 prescribed medications within a health system. So if the stewardship program is going to overall look at antibiotic use, then it's going to be critical that that stewardship program communicates well with the entire health system. And so here are a couple of ways that we do that at UCLA. We have a website. I would encourage you to visit our website. Our website has best practices, the lab antibiogram, lots of different resources for our clinicians as they are thinking about stewardship. Then we have a real-time app. This is through First Line, and that app not only contains the lab antibiogram, but also treatment guidelines for individual different infectious diseases, so that a clinician out on the wards looking at a patient has a certain infectious disease, needs to give empiric therapy, because the lab has not produced the data yet for targeted therapy, can go to this app, open it up, and have resources on hand for stewardship. So the UCLA health system is large. We have somewhere around 6,000 treating clinicians and impact 2 to 3 million lives a year. Our stewardship team is not that big. And so you can imagine we can't have individual conversations with 5,000 clinicians. And so you have to be able to standardize and set guidelines. And these are some of the ways that we do that. Just sharing some of the reported data that we use. And so this is tracking antimicrobial days of therapy per 1,000 patient days for each individual floor and area of our hospitals. So for example, I've boxed some of this. This is our 8 ICU. So 8th floor ICU. This is our 4 ICU, 4th floor ICU. This is our 7 ICU. And they have different specialty services. Like 7 ICU is liver, 4 ICU, general medicine ICU. And what we do is we track and count how much antibiotic is used overall in each one of these areas to look for outliers. And so you can see here, the 8 ICU uses more antibiotics on a regular basis than anywhere else in our entire hospital. Now, that doesn't mean that's wrong, right? Our 8 ICU sees our sickest patients. And in that setting, they often have both chronic disease and infectious disease. And so it's not to target areas for usage, it's just to understand your usage. And if there is an area that's using more antibiotics than any other area, well, we need to look at that, right? Maybe it's appropriate, maybe it's not. And so here we're tracking on a yearly basis, looking at what's happening there. The larger regulatory bodies actually track things like carbapenem use between hospital systems. And so you'll get a report after you turn in your antibiotic usage report in a national survey. You get a report back to show you how you are doing compared to other centers that may be seeing similar type of patients. So this is the liver transplant data, right? So for centers that are doing liver transplant, the question is how much carbapenems are you using? And you can see at UCLA, we use a lot, right? You can see there are other centers, Cleveland Clinic, Mayo Clinic, Ohio State, University of Pennsylvania, Mount Sinai, that are using less. And so this is something to think about as an institution, right? Are there ways to reduce carbapenem usage? We know carbapenem usage contributes to antimicrobial resistance. Also, for patients that have the right infection, cures patients. So there's going to be an appropriate use of carbapenems. The question is, what do we do about overuse? And it's hard to know if you're overusing if you don't have these standards lined up. But I mean, this is national resources have to go into this, right? UCLA can't put this together. We can contribute our data. So antimicrobial resistance and antimicrobial stewardship is really it's a national effort. It's a governmental effort to be able to fight these things and allow hospital systems and stewardship programs to know how much antibiotics they're using compared to their peers. Best practices are what these sorts of conversations bring about. All right, so I want to pivot to the lab, and I really want to spend sort of the last 20, 30 minutes we have together focusing in on the role of the laboratory in stewardship. We've already laid out how important this is, how impactful this can be, and how I want to point out now how the lab can put in best practices to support this work or play a key role. So the CDC has thought about this as well. So these are the CDC's key activities and roles for microbiology lab staff, for us, and antibiotic stewardship programs. So the idea here is we want to integrate the micro lab staff into the functions of the stewardship program. And this is sort of based around 5 bullet points. 1, diagnostic stewardship. Is the right test available? And test availability is a big deal. We all know this on the call. If you don't have the right test available, you can't support your clinicians, you can't support your patients. And is it being used appropriately? That's stewardship, diagnostic stewardship. Is there an antibiogram? And is that antibiogram in use to support empiric therapy? And we're going to walk through that. Is the lab introducing new diagnostic tests? Tests that can potentially improve stewardship? Is the lab implementing antibiotic susceptibility testing interpretive criteria that's up to date? As CLSI or UCAS comes out with changes in breakpoints, are they being implemented for better treatment? And then is education happening broadly? So let's tackle some of these and show how these can be useful. So one, diagnostic stewardship. How does the lab help to optimize testing practices that impact stewardship? So one, and this is a constant battle in the laboratory, how do we improve test ordering menus and order sets? You have a set of tests that are available and no one is ordering them correctly. Your physicians are not experts in this space. And so we do a lot of this in our EDs. If a patient comes in with a certain set of conditions, we present that clinician with an optimized order set that we have come up with in stewardship, working with infection prevention, that would be the best set of test orders for that disease state. That way, nothing gets missed. That way, yeah, you ordered a COVID PCR, but you didn't actually order any bacterial culture. So let's give you COVID PCR bacterial culture as a single order set that you can click on and then order. You don't have to think your way through that process and the right tests come in. We work hard on improving sample collection practices and quality of specimen. We all know in the lab this mantra, garbage into the laboratory, garbage out. If the wrong specimen is collected, we're not going to be able to provide great data on the microbiology side. So we work very, very hard in a system that is as large as ours to make sure that the best sample is collected. Get that blood culture before antibiotics have been placed on the patient, right? Key to blood culture effectiveness. We work very hard in that space. That's stewardship, right? I think we do a lot of these activities as laboratorians, as lab, and don't think of them as stewardship. They are stewardship. You want to ensure the lab procedures reflect best practices in workup specimens, susceptibility testing, and result reporting. Are we putting out data that helps our clinicians use the results and an impact for our patients? So, for example, I'll consult and work in a lot of places globally where, unfortunately, the antimicrobial susceptibility testing that's happening in the laboratory are not the same drugs that are available on the lab formulary. This is a misalignment, right? We should be testing the drugs in our lab that are available for our clinicians to use, because that ends up providing the best data. So there has to be alignment there, and stewardship can help in that alignment. But you need to have lab as part of the stewardship team for that. We want to report lab results in a way that encourages antibiotic therapy, appropriate antibiotic therapy. So this is a really big example. So when we have a respiratory culture, what we will typically do historically is say normal respiratory flora seen, right, on a sputum culture. This is common practice for a lab. The problem is a lot of your clinicians don't know what normal respiratory flora means. And so if you say that, maybe the clinician assumes, well, normal, but I'm going to continue coverage for Staph aureus and Pseudomonas because the lab didn't tell me they're not there. So we actually took this as one of the improvements that we made, that on the bench, when our laboratorians see normal respiratory flora, our comment now says normal respiratory flora, no Staph aureus, no Pseudomonas aeruginosa found. Just flat out, it's not there. We implied it wasn't there by saying there's normal respiratory flora, but now we are specifically saying that. And when you do that, you see a reduction in antimicrobial usage for coverage of Staph aureus and Pseudomonas. So you can see it's just, that's a small change. We didn't do anything on our side other than change our reporting structure for normal flora seen in sputum, and it reduced inappropriate antibiotic use. That's a huge win, right? I didn't have to bring in a new diagnostic test. I didn't have to implement something very expensive, and I was able to establish improvement in antimicrobial usage. And then you want to consider adopting diagnostic tests to optimize antibiotic therapy. I will be honest, a lot of these tests are incredibly expensive. So when we look at things like blood culture ID, a system that uses a multiplex PCR after blood culture positivity, this type of thing is far too expensive for a lot of the world. So I think that's challenging, but I hope that new, more affordable, but also great performing diagnostics are coming to be able to improve patient care in this space. Okay, education. So promoting education and communication between the lab and clinicians about test characteristics is important. Having some kind of lab formulary website where a clinician can go and just get basic information about the tests is critical. Test performance, expected turnaround time, what's the best specimen to collect? Our health system, and not just infectious disease, but overall all clinical lab testing, we are in the range of 18 to 20 million test results a year coming out of our system. We can't possibly talk to our clinicians as they are making those decisions. And so being able to have available education and having clinicians know where to go when they have questions is an important part of education. We also want to educate our clinicians on interpretation of test report. So they need to know in antimicrobial testing, what are the categorical interpretations and what does it mean? So if we say the drug-bug combination is susceptible dose dependent, that doesn't mean a lot of things to a lot of people. That means something to your infectious disease clinicians. That means something to your pharmacists. I don't know what that means overall to a treating clinician that has less experience in that space. So in stewardship, we then write into the report what it means. And so when a report goes out from our lab that says susceptible dose dependent, right underneath is a sentence that says, this is a difficult interpretation for antimicrobial reporting, and you should contact an infectious disease doctor if you want to use this particular antibiotic. Just advice in the report for the clinician to be able to understand and interpret the data. So all of this ends up being critical from the lab side. Now, when we look at reporting, one of the big things, and the thing we'll spend sort of the last part of this talk on, is an institutional antibiogram. So an institutional antibiogram is a set of data coming from the lab that talks about the resistance that is seen for as many bug-drug combinations as possible locally within a healthcare system. And the reason this is important is because understanding your typical resistance rates allows a clinician to make an empiric treatment decision while the lab is performing susceptibility testing, right? We in the laboratory, we work as hard as we can to grow bugs, to identify those bugs to species, and to do susceptibility testing as fast as possible. But that's still a 2 to 3 to 4 day process. And in that time, most patients are going to need to be treated if they have a bacterial infection. And so the goal of the institutional antibiogram is to guide patients in those treatment decisions while the lab is working that up. So how do we build this? What does this look like? So we report on the percent of isolates tested and found susceptible. We only present results for organisms and settings with sufficient numbers of isolates tested. If you only grew one Pseudomonas that year, And in small hospital systems, this could happen. If you only grew one Pseudomonas that year, if that bug was resistant, you can't say that all Pseudomonas coming through your hospital institution are going to be resistant, because there just isn't a large enough representative population there to make that call. You also want to follow standardized procedures for deduplication of multiple results from the same patient. So why is this important? A patient will come into your healthcare system with multi-drug resistant Pseudomonas, and they'll have culture after culture after culture after culture, right? They're going to run blood cultures until maybe those blood cultures stop being positive. You're going to continue to grow that bug over and over and over again in the lab. Well, that's one patient and one bug. But if you are setting your antibiogram based on just the lab data, right? Not the patient, but just the bug itself, you overrepresent that bug in your antibiogram. And so you want to be conscious of sort of that piece. And then where possible, if the numbers are big enough, you want to stratify your data by major clinical area. So potentially, and I'll show you this with the UCLA data, potentially your outpatient resistance rates, I mean, hopefully, are lower than your hospitalized resistance rates, right? All the bad bugs live in the hospitals because that's where all the antibiotics are. That's where resistance is bred. And so in that setting, you have clinicians making antibiotic treatment decisions in many areas of your hospital. In the ICU, I want our ICU docs to know the ICU data. In our outpatient setting, I want them to know the outpatient data, because there are drugs you can use in the outpatient empirically that you would not use in the ICU because the resistance rates are too high. And so we're going to go over all of that. So I want to give you, sort of in the last 15 minutes or so, an in-depth look at the antibiogram that we produce in the clinical microbiology laboratory. So this is all produced from the Clin Micro Lab side for our clinicians each year, hand in hand with our stewardship team. And so our stewardship team, the MDs, the pharmacists, they are reviewing the draft of our antibiogram and making changes as we put it out yearly for appropriate treatment use. And it is one of the most impactful interventions that the stewardship team does, is putting together an antibiogram. So let's look at UCLA's antibiogram. I don't mean to overwhelm. So I know this is a lot of data. And so I want to walk through how we do, because we set this up as tables. And so let me introduce you to Antibiogram UCLA Health Table 1. This is a table of adults with the most common gram-negative infections that are non-urine. And the numbers that you see are percent susceptible numbers. So again, a clinician should look at this and be thinking, what empiric therapy should I use for this bug that's been identified in a non-urine infection? So the way we have this organized is on the y-axis, we're grouping the data by organism. So for example, this is all of the E. coli for an entire year isolated in my microbiology laboratory, non-urine isolates. So you can see we had about 1,000 non-urine isolates overall. We divided up by location. So outpatient, we had 374 E. coli's that were non-urine. Inpatient, 461. And then we pull out ICU, because ICU, this is some of the more critical areas where you need to make the right treatment decisions. ICU, we had 147. First point, it's all above 20. If you aren't collecting more than 20 isolates of a single bug, then it's going to be very, very difficult for you to have an antibiogram, because the data there isn't strong enough to make some sort of summary recommendation. And so what I will suggest to places that are doing less numbers than this, that have less than 20 over a year, use 2 years of data. Use 3 years of data. Get up to a number that you can use to be able to have a consensus estimation of resistance. So here then, we have the number of isolates, the location, and then drugs that we test. And as we all know, we don't test drugs one at a time. We test drugs in a panel. And so this is representative of the panel of drugs that we test for all of our gram negatives. So you can see we have the penicillins, the cephalosporins, the carbapenems, aminoglycosides, fluoroquinolones, and a line for Bactrim. So I want to dive into the data here a little bit to show you how this can be used appropriately. So again, we put this out every year. And the first thing you want to do is you want to make sure that clinicians aren't using antibiotics inappropriately. And most clinicians, non-ID, which remember, that's most of the people that will be working, don't have memorized what organisms are intrinsically resistant to what drugs. So for example, Pseudomonas is intrinsically resistant to ertapenem. You can't use ertapenem on Pseudomonas aeruginosa. So that's what this R here means. Clinician opens it up and for whatever reason is thinking, wow, my patient's on ertapenem, they now have a Pseudomonas infection, the lab's doing susceptibility testing, they're doing their work. Can I keep them on ertapenem? Look, ertapenem is intrinsically resistant. We have to change the antibiotic. So it's just giving that upfront information for your clinician. So that's what the R's mean. Then overall, when you look at the numbers represent percent susceptible. So let's look at E. coli. So our E. coli's overall in our health system, outpatient, inpatient, and ICU, have a pretty good susceptibility profile to piperacillin tazobactam. Why is this important? Piperacillin tazobactam in our institution is the most common gram-negative antibiotic used for empiric therapy. So if someone comes into our healthcare system, they're put on pip/tazo, if they have a bacterial infection, or if on the differential bacterial infection is there, while the lab works up specimen, gets an ID, and does susceptibility testing. So is that a good empiric antibiotic? Well, for the inpatient setting, we have a 90% susceptible population. For the ICU, you have an 82%. We're getting down to a number here that you may want to consider changing drugs in the ICU if the lab tells you it's E. coli. Let's look at ESBLs, right? So extended spectrum beta-lactamase producing organisms. So ESBLs can have resistant to ceftriaxone. And so if we look overall, what are our ceftriaxone rates of susceptibility? You can see in the outpatient area, 80% susceptible. On the ICU side, 60% susceptible. So ceftriaxone is not a good drug in the space of the identification of an E. coli because you have the 40% likelihood that that's going to be an ESBL producing E. coli and you should make another drug choice. So again, empiric treatment decisions targeted by laboratory data. Let's look at Pseudomonas. So, Pseudomonas is a scourge, a bug that's very, very difficult to treat, very high morbidity and mortality. And let's look at our pip/tazo rates. So again, patients are on pip/tazo, piperacillin tazobactam for gram-negative coverage. If we look at that patient in the typical inpatient setting, there's an 80% susceptibility. If we look at that patient in an ICU setting, 65% susceptible only to piperacillin tazobactam. We track this year after year, and this number has just been getting worse and worse and worse for our Pseudomonas. So this is how you use an antibiogram table. You go in, you have an interest, a patient is either on a drug or you want to use a drug. The lab has provided some level of data on identification, but you are in this 24-hour, 48-hour waiting period for susceptibility results. Here's how we can show there's targeted therapy. Here's how you can use the years-long data to be able to guide those therapy decisions. We then make these tables for different groups of patients. So that first table, gram-negative bacteria, non-urine. This table, gram-negative bacteria, urine. So as we all know, urine cultures are one of the most common bacterial cultures that are performed. Here you can see we isolated 9,000 E. coli's last year in our system, and we divide this up just outpatient to inpatient. Interestingly, our outpatient ESBL number is only 10%. Our inpatient ESBL number, 28%. So again, as our clinicians are trying to think about what drugs to use before the lab puts out sort of that individualized susceptibility profile for that bug, treatment decisions can be made in that space. Looking at gram-positive cocci now, right? So for our gram-positive cocci, we have a lot, unfortunately, of MRSA. And looking at that MRSA, you can see the difference here between susceptibility and resistance profiles from MRSA to MSSA. So of course, in our methicillin-resistant Staph aureus, they're going to be resistant to all of the penicillins, and penicillin is beta-lactam drugs. But even when you move to other drugs like ciprofloxacin, clindamycin, you can see that while our methicillin-susceptible Staph aureus are reliably susceptible to ciprofloxacin, our methicillin-resistant Staph aureus are completely resistant. And so being able to understand as quickly as possible, is this methicillin-susceptible Staph aureus or methicillin-resistant Staph aureus, completely changes the treatment profile for antibiotics. So that means a lab like ours should try and bring in rapid diagnostics to understand the difference between MRSA and MSSA. Because if we're able to just give that piece of information, right, whether it's a MEK-A PCR or a PBP2A antigen flow, lateral flow test, they have really, really strong correlation with great treatment decisions if you're able to differentiate these two. So again, it's a rapid diagnostic method of being able to help in stewardship, help in therapy, and this table just sort of represents how important that ends up being. Pediatrics. Now, I put this one here because we are a center that sees a lot of adult patients. We don't see as many kids. And so in that setting, our tables for kids, so this is our pediatric gram-negative bacteria table for urine isolates only, percent susceptible. You can see for E. coli, we've got plenty, 882. So just from kids, our pediatricians can use this data. It's not divided up inpatient and outpatient, it's just all the kids together. But for something like Klebsiella or Enterobacter cloacae, we don't have appropriate numbers, only 17 isolates of Klebsiella last year. So we caveat this by saying this data is not supported statistically, but we want to give it to you anyway, because potentially it can help in a treatment decision. So again, just allowing the numbers to guide overall in our advice to our clinicians. Now, what do we do about multi-drug resistant organisms? As I said before, our Pseudomonas rates, our resistance rates are increasing to things like broad gram-negative coverage like Pip/Tazo. So if we look at our carbapenem-resistant Enterobacterialis and our Pseudomonas, we have drugs that target these organisms. We use ceftazidime-avibactam. We have ceftolozane-tazobactam, and we continue to monitor our percent susceptibility. The unfortunate reality of antimicrobial resistance is these bugs are going to beat these drugs at some point as well. This is just a continual race. And so, unfortunately, race to the bottom. And so we monitor year after year. Unfortunately, right now, out of our 324 total isolates that are carbapenem-resistant Enterobacterialis, 95% of them have been susceptible to ceftazidime-avibactam. So it's still a great drug. But for the 81 isolates that have been tested for meropenem-vaborbactam, only 85% susceptible there. So we continue to watch this year after year in order to implement change if we need to. Now, for Pseudomonas, it's especially important because we can take Pseudomonas that are either resistant to imipenem or meropenem, or even worse, a group of Pseudomonas that are resistant to imipenem and meropenem. And you can see, like, if the Pseudomonas is resistant to imipenem and meropenem, it only has a 28% susceptibility to Pip/Tazo. And so we look at numbers around drugs targeted for this bug, like ceftolozane-tazobactam. We are still only at an 83% susceptibility. And so there are going to be bugs that are Pseudomonas that are multi-drug resistant that you won't be able to use some of these drugs. So year after year, we track this in our system. Just to finish up, the last couple of slides, we grow a significant amount of yeast, clinically relevant yeast that needs to be treated. No, so not mucosal infection, but systemic infection, bloodstream infections, pneumonia. We have a fair amount of neutropenic patients, and we track our bugs we're seeing. Candida auris isn't included on this, but we also have Candida auris. The bugs we're seeing, like Candida albicans and glabrata, and then the percent susceptibility to things like azoles versus echinocandins. And here you can see, while our Candida albicans infections are 90% susceptible still to fluconazole, our glabrata actually have no susceptible isolates. 84% are susceptible dose dependent, and 16% are full-blown resistant. So if the lab isolates a Candida glabrata, this data suggests that an echinocandin should be put on board, because ultimately it's going to take a day or two for us to work our way through the susceptibility testing for these isolates. We have tables that highlight emerging resistance. So just to wrap this up, we talk about Pseudomonas and what type of isolates are there and the percent resistance. We track over time our rates. So you can see our VRE blood rates are going down while our MRSA blood rates are staying the same. And this is over more than a decade. We track our E. coli ESBL rates. These are going up. We track our overall carbapenem rates to be able to understand the changes in our healthcare system and what we need to think about as stewardship. We have treatment suggestions for things where usually susceptibility testing isn't performed, like what should our clinicians do if our patient has Bordetella pertussis? We have recommendations that are in our antibiogram. We track our blood culture results and other things as well. So just in the interest of time, to save time for questions, I'm going to stop there. I really appreciate everyone's time, and I hope you found the talk informative.
Thank you very much, Prof. Garner. We really appreciate your talk. That was really showing us how stewardship then, when these programs are there, practical, will be able to help. You highlighted our role as the laboratory, and also how we can then also work in multidisciplinary committees, which is important. And also, we are excited about data collection because that's what informs everything else. And it's interesting to see data collection varying actually in the same hospital. Different facilities or wards can then be used differently, and treatment can then be impacted and implemented differently in the same facility as well. We have few questions. We'll do our best just to cover what we can now. And for those that we are not going to be able to cover, I promise then the participants that we will give them to Prof for him to be able to look at them and also give us feedback. The first question from IOP says, how do policy regulators inspect the drug efficacy in conflict-prone regions as illegal drug import is rampant thereon?
Yeah, that's honestly a difficult question that I do not have a lot of experience in. So antibiotic drug regulation in the United States is very well controlled. And so we don't see sort of drugs coming into the market that may be ineffective because they are sort of illegally made. And so you're not getting what you think you're getting because of the flooding of those drugs on the market. So I don't have a good answer for that, unfortunately. I know that is an issue globally. I think it's a government regulated process that needs to happen. So our FDA regulates that in the US. But yeah, I know that is a problem, but that is not something that we see.
Thank you. Thanks for your response. The next question is, what's the main goal for antimicrobial stewardship? I know you covered it after the question was posed, but just in summary.
Yeah, I mean, to me, it's about patient care, right? We need to do the best things for our patients. So the main goal for me in antimicrobial stewardship is really making sure that our patients are best taken care of when they have a bacterial infection. And that means they're getting the right antibiotic at the right time. And so that I think is the overall goal. Now, what's nice about achieving that goal is you also fight antimicrobial resistance. And so if you're able to do these things, we sort of bring down that epidemic of resistance that we're seeing.
Okay, thank you very much, Prof. The next question says, isn't it okay to include other antibiotics not available to clinicians so that when all antibiotics commonly prescribed at the facility turn out not to be effective, you can opt for the others? It's a different one.
Yeah, this is something that I've actually talked with some colleagues, because if you are testing antibiotics that are not available and they're effective, potentially that can be used as an argument to the healthcare system to buy those antibiotics. So I do think that there is some advantage there. I will say, though, alternatively, if there are antibiotics being used that are not being tested, because that gap exists as well, that's the most important thing to target, is to try and test the antibiotics that are being used in the system. Then beyond that, if you're already doing that, testing other antibiotics because it's what the system wants to make an argument to use those. Yeah, if the lab has capacity and is able to do that as part of a panel, I think that can be a good strategy to be able to figure out a way to get more antibiotics.
Oh, thank you, Prof. I always say to people that yes, you can do the testing, but limit your reporting so that then you can be able to channel and know then how to monitor that resistance as you report. As long as you keep the data in the laboratory, it will then be advisable for you to have that. But at the same time, you'll need to balance resources and how many antibiotics are available at what stage as well.
Yeah, I
So,
completely agree. I'll actually make a comment on that, patients, as well, because I agree with you so much. Cascade reporting is critical in the lab. So you test a bunch of drugs, but that doesn't mean you tell those clinicians that all those drugs have been tested. You tell them first line antibiotics, that the ones you want them to use. And then if those are resistant, you tell them the second line antibiotics. But if you just give them everything, treatment mistakes can happen. So I agree that the lab's ability to effectively distribute data when it is clinically relevant is an important job of the lab.
Thank you. Unfortunately, due to time, we are not going to be able to take all the questions. We will share them with Prof, and we will ensure that they do come back. Time is not on our side. Thanks, Prof. Garner, for being with us. So we really are excited due to the really excellent presentation that you gave us and engaging really. I think the audience were as excited as we are. Your knowledge really is helpful, and we are seeing the advantages of collecting the data through what you are doing.
Yes, just to let everyone know, I think many colleagues are really sharing some appreciation to you, Prof. There's a lot of messages here that's saying, very top presentation. We really appreciate this. I think I like also the angle that you used to kind of highlight how the lab's role, because people are just working in silos doing the testing, but never translate that to actual stewardship in their local settings. So just to let everyone know that we will be sharing the recording of this presentation as well as the presentation itself. I apologize for the background noise. We will be sharing that. Otherwise, really, Prof, maybe just to hand over to you for some closing remarks on your side as we close. Thank you.
Yeah, it's really been an honor to be here. I'm glad that the talk was appreciated, and I am happy to answer questions. And so as Sylvester and patients pass questions on to me for this talk, I apologize we didn't have time to get to them all, but I will respond by email. And I just am honored to be here, and thank you all for your time.
Thank you very much, Prof. Really appreciate you. So as mentioned, we will be sharing the questions that have not been answered for you to respond, but we've tried to kind of answer some of the questions. Otherwise, really, everyone, we really try our best to keep getting people like Prof. Garner here to share their experiences and their thoughts that can also help us reflect on what we are doing on our sites as well. Otherwise, wishing you all a great rest of the day and a blessed weekend ahead. Thank you so much, Prof. Garner, and have a great day ahead. I know it's super early your time. Thank
Just
you.
starting the day. Thank you all.